have his talk, the first talk on the PG classes, which we have started due to the pandemic this year.
Thank you. Thank you, Dr. Edward. Thank you, Dr. Edward, for the nice words. And let me congratulate you and your whole team, Ratesh, and all the team for initiating this teaching program to our postgraduates. In this difficult period of COVID, it was well thought of that we should initiate this teaching program. And you have really started this program. And all the best and congratulations to you. We'll all be a part of the team, and let us know if there is anything we could do on this particular aspect. I gave different subjects, and you have selected polytrauma early, total care versus damage control, orthopedics. Mainly the concept of polytrauma, because the postgraduate should know what to do and what not to do when a patient comes to the casualty. You may be wonderstruck to know that nearly 150,000 people die in our country every year because of road traffic accidents. And more than about 6 lakhs of patients are injured in these particular accidents. And it is very important that the time concept from the time of accident to the period he reaches the hospital, and immediately after he reaches the hospital, what is to be done, which can save many lives. So this talk for another half an hour to 40 minutes will mainly entail what is to be done and what is the concept of polytrauma today and what is early total care and damage control orthopedics, which every postgraduate and a treating surgeon should understand the concepts and the strategy, and the most important is the decision making as to what to do for a particular patient when a patient comes with polytrauma. What is polytrauma? And up to 2014, polytrauma was defined as any injury which involves fractures with one vital organ being involved. It may be liver, it may be lung, it may be any injury in the stomach or the brain. But after the 2014 International Conference on polytrauma, the consensus was raised that any injury of two vital structures, it may be even two bones, or a bone and a liver, or a liver and a brain, if there are two vital structures involved, then it shall be called a polytrauma. But one should understand the definition is not very important. What is important is to know that polytrauma is not just a collection of fractures. It is a systemic insult which occurs to the patient who was healthy otherwise. And then the patient comes to you, to the casualty, mainly the patient will have lower physiological reserves, which has to be noted, and with an associated vital organ injury. A vital organ may be any one of the vital organs which you know. Before 1960s, as a postgraduate, I still see this picture in my mind. In our ward, the polytrauma patient was thought to be too sick for an operation. So he was really put on different types of traction. Even now, some of the hospitals still may be having the old pictures of these different types of. This was the Pearson attachment traction, which is put to the upper the lower end of the femur and the limb being hung, or it may be a traction with a bonus splint or a Thomas splint. And it was thought in 1960s that surgical stabilization of log bones fracture is not routinely performed, and usually they were treated either with skeletal traction or with plaster casts. This great visionary, which as a history every postgraduate should know, because I feel he is one of the greatest pioneers in orthopedic surgery who gave us the Kuncha nail. Though he gave the Kuncha nail in 1940s during the Second World War, it was he who published for the first time the role of nailing in long bone fractures, especially of the femur. And it was up to 1970, almost after 25 years it took, That pioneering studies till then showed that early stabilization, especially of femoral fractures, dramatically reduced incidence of fat embolism syndrome, incidence of pulmonary failure in ARDS, and also postoperative complications like Bexor and various other complications associated. Then 10 years passed, and Larry Bone from United States came out with the ARC paper. And late 1980, he said there is beneficial effect of early stabilization of fractures on both mortality and morbidity and length of the hospital stay. This new philosophy in the management of patients with multiple injuries was named in 1980s as early total care. Early total care meant you treat all the fractures and injuries on day one before 24 to 48 hours, and from the patient being too sick, it was found that the patient is not too sick to be treated surgically as early as possible. So the early total care concept came better fixation techniques with the development of intensive care supported with this more aggressive approach. And patients were able to mobilize early. And the next day, they were able to walk with a pair of crutches or with a walker and were discharged soon, avoiding complications and prolonged bed rest. And all these papers, from Larry Bone to Vishka to Goris, best operation for a patient was considered to be day one, early, and a definitive procedure. So the management of polytrauma patients have improved significantly as a result of better understanding pathophysiology today and the development of network of pre-hospital trauma management, especially in developed countries, and the institution of multi-specialist integrated groups. We must understand for a polytrauma patient, what we require is not just the machinery in the hospital, but a multi-specialist integrated group to treat multiple injuries and improved ventilation and ICU strategies is a must, and also the nutrition of the patient. So it is a teamwork. It is not just an orthopedic surgeon or a thoracic or a general surgeon who treats these cases. It's a teamwork which optimizes the correct treatment for this particular patient. So with a better understanding of pathophysiology, you mean with changes in the immune system, what occurs. And hyperinflammatory phase followed by a hypoinflammatory phase were described, which precedes an organ failure, which has to be understood. And definitive fixation and first 24 to 48 hours following injury was the theme there. So the advantages of early total care were early mobilization, as I told you, and lesser ICU care, lesser hospital stay, and lesser hospital expenditure. The longer you stay, the expenditure goes up, and less incidence of complications. All these papers envisaged it up to 1995. So the advances in trauma surgery, anesthesia, and critical care medicine, and which enabled orthopedic surgeons to perform definitive operations early in multiply injured patients. Clinical parameters for decision making. These are the clinical parameters. When can we really operate on this patient? They had definitive clinical decision for decision making parameters. The systolic BP 120 by 80, and a heart rate preferably not more than 90, and a CVP which is normal, the hematocrit values being normal, and the cardiac index has to be estimated, and the pulmonary artery pressure has to be estimated normal, and also important is the coagulation profile. Many of these patients would die because this coagulation profile was not undertaken and the bleeding diagnosis. And also important is the acid-base balance, which many times is forgotten in an intensive care. And so there was a balance which went on between benefits of early total care and potential second insult. Second insult means the first insult is that, and the second insult, where will there be a second insult which will cause a change in the immunological response? Will there be a change in the acid-base balance? Will there be a change in the pulmonary function? Was to be taken into consideration. So in about just 10 to 15 years of time, that was in early 1990s, and this thought came into being. outcome, when we studied the outcome after ETC, early total care, there was increased incidence of ARDS and multiple organ failure, and mainly developed in patients with severe chest injuries, which the surgeon thought, even with chest injury, I will go ahead and do a nailing or fix all the fractures. And severe hemodynamic shock, which was not taken into consideration. And added to the list was post-stream intramedullary nailing causes and complications. Then the question came, was ETC really safe? Early total care really safe? Pepe of Germany came out that patients with high injury score had high mortality rate even when treated early. And this was the classical article in 1995, and it evoked all of us. And he also asked the question, are some patients actually too sick to operate? And in severely injured patients, invasive fracture fixation. Surgery stimulates a secondary inflammatory reaction, which is called surge, which is called the second hit, and detectable by an elevation of pro-inflammatory cytokines. And this has to be taken into consideration. All these papers envisage this, the importance of pro-inflammatory cytokines. So it resulted in multi-organ failure. The cytokine response evidenced by fever, leukocytosis, hyperventilation, and tachycardia. Commonly seen in injury is referred to as systemic inflammatory response syndrome, SIRS. Remember this SIRS. This inflammatory reaction has been implicated in the development of ARDS and multi-organ failure. I repeat, this inflammatory reaction has been implicated in the development of ARDS and multi-organ failure. So the second hit concept came into being. What happens with the second hit? There is a neutrophil priming, which occurs because of the inflammation. And thereby there will be a neutrophil activation and a remote organ injury, which can accentuate an ARDS-like phenomenon. So 1990, with all this thought, the new concept came into being, which is called the damage control. DCO, the damage control orthopedics, an approach that contains and stabilizes orthopedic injury so that the patient's overall physiology can improve. So instead of ETC, the concept of DCO came in. Its purpose is to avoid worsening of the patient's condition by the second hit, which I described, of a major orthopedic procedure. This word, damage control orthopedics, it was presented to the world by the shippies who, when the ship was about to break down, and they would try to save the ship by whatever means they can, by throwing out whatever weight or gasoline or in the ship, and their ultimate aim was to save the ship. And similarly, in damage control orthopedics, the ultimate aim is to save the patient by whatever means you can. And remember, an orthopedic therapy for a second hit requires all these paraphernalias. That's why you must be very careful. And prevention is better than trying all these means to save the patient. So how do you prevent? The risk stratification. Pepe came out with the risk stratification of polytrauma patients who are risky and you should not operate, and who are not risky, and what are the criteria. Polytrauma patients are stratified into 4 distinct categories today based on injury severity scores and physiological response. Are they stable? Number 1. Number 2 is borderline. Number 3 are unstable. And number 4 are extremist, where the patient is almost gastric. So what is important to understand each of these to save the patient? Majority, 60 to 70% of our patients belong to that borderline group. So it is very important to understand the borderline group to save these patients. So the risk stratification, the borderline is defined by one of the following conditions, where the injury score is more than 40, where the injury score is more than 40 with chest trauma. Important is that chest trauma and hemorrhagic shock and abdominal trauma or pelvic injury associated. radiographic evidence of pulmonary contusion if it is there, and moderate or severe head injury, and bilateral fracture shaft of the femur, and the body temperature which is less than 35 degrees. And any two of these conditions, or even one, has to be taken into consideration, especially the chest injury and the abdominal injuries, or the temperature which is below 35 has to be taken into consideration, and call it borderline and assess the patient, then do whatever is necessary. So the word lethal trial, the triad came into being, which comprises of hypothermia, as I told you, acidosis, and coagulation. This is the deadly triad, and if the patient has all the three, it is dangerous. So inadequate resuscitation and prolonged surgery is a deadly combination added together. So that picture of trauma triad of that, which shows increased lactic acid in blood and acidic blood and decreased heart performance, thereby low body temperature and decreased coagulation outputs with a severe blood loss, and we can lose the patient if we do not diagnose it early. So there is a time of window of opportunity. And what is this time of window of opportunity? When is the patient fully resuscitated is important. So endpoint of resuscitation are, if in 24 hours you see that the stable hemodynamics is there without vasoactive or inotropic support, where the serum lactate is less than 2.5, which is important. There is a normal coagulation, normothermia, and normal renal function. That is, urinary output as more than 1 ml by kg per hour. If these criteria are there, you can go ahead and do a total care. Otherwise, you swing on to the DCO, that is much safer. So early total care in developing countries, what is it? What I mentioned, early total care, all are on in well-developed countries where every facility is there. Is it feasible in our country? And if so, how we can really do it? Look at this many times in our country. There is no ambulance service. Many times, if you call the ambulance, they come 1 hour late. Then that is too late for the patient. And no paramedics. Even if there is an ambulance, the driver there is no paramedics in the ambulance who can resuscitate the patient at the site of accident or in the ambulance itself. And there are no trauma centers nearby. And local hospitals lack the infrastructure, staff and lab, and even a blood bank in some of the towns. So they will have to travel long distances in roads, as you see on the right side, which takes nearly 1 hour for 20 kilometers. So that is this. When that is the situation, is early care possible at all? Is the question. So the awareness and readiness, both on part of the government and the people and the local organization, is paramount for saving this polytrauma patient. So in between, I told you what is early total care and what is DCO. So in between DCO, a term called early appropriate care came into being. It was Valius in 2011 who came out with this particular concept, that what is early appropriate care? That is to stabilize the patient, and if there is a fracture shaft of the femur, prioritize fixation and care of open fractures. If there are open fractures, you put an external fixator and with aggressive rehab. That is early total care. So the concept of 2010, from 2010, we are in between 80, the early total care and DCO and early appropriate care in between. So this really shows what is early appropriate care. And if not, if you to save the patient, you wait on the till 5 days that the damage control orthopedics with whatever control, whether you control the bleeding, control and resuscitate the patient and then undertake surgery, or take an early total care. So early appropriate care, preferential management of the femur, but not necessarily other extremity fractures, which are splintered initially and dealt with later. And this is the whole concept. So it is limited use of DCO and resuscitation prior to stabilization of femoral fractures and adequate resuscitation prior to surgery. This All the studies now have proved early to that if you undertake and early appropriate care, the patient will be much better off if they are assessed properly. So the decision making is whether it is ETC versus DCO or early appropriate care. There is evidence that DCO procedure minimizes the incidence of second hit insults, and DCO is faster and lower blood loss compared to ETC. And ETC is safely performed in stable patients, as I told you. I gave you the criteria of stable patients, but is associated with higher mortality in borderline patients. So it is the majority of the borderline patients which you will have to be careful about. So the temporary external fixation, what does it do? In a DCO, external fixation will take 35 minutes, whereas a real femoral nail with the best of the hands may take about an hour or two. So that and the blood loss will be much more. This also has to be taken into consideration, and this study shows that. So the temporary external fixation, and in this study they proved that there was 97% union rate and underwent secondary intramedullary nailing after the condition was stabilized. So gentlemen, the concept is if it's a stable patient, as I envisage, it is early total care. If it is a borderline patient, you will have to, if required, shock room, hemorrhage control, and reevaluate the patient. And if the ABG, ultrasound, urine output, and inflammatory response is good and the patient is stable, we swing over to early total care. And if you are uncertain that this patient has immediate the inflammatory response and the respiration is not good, then you switch over to DCO. And if you can, and if you are good enough, you go into the in between one early appropriate care, fixing the femur fracture. And majority of the patients, as I told you, belong luckily to the stable and borderline, and your decision is vital in these patients. So surgical priorities in polytrauma patients, timing and physiological status. Remember this data. If it is a stable patient, you operate on day one. If it is an unstable patient, it is damage control orthopedic. If there is hyperinflammation, you have a second look, like in pelvic injuries, the change of packing between second and fourth day, and relook on the wound. And time window of opportunity is between the 5 to 10 days, scheduled definitive surgery, and immunosuppression. And there is no surgery at all, and you take it after 10 days, and about 10 days, with the immunosuppression office. And when it recovers, the secondary reconstructive surgery can be undertaken only after 3 weeks. So remember, day one, 5 to 10 days, and again after 3 weeks. In between, you shall not do anything. So the susceptibility to 0, 1 to 4, and 5 to 10 days is the window of opportunity, and after 3 weeks is the second, after the immunosuppression. So DCO versus ETC is not a major philosophical argument, but rather a difference in time, thresholds, and technique magnified by your institutional differences. You understand which institution you are in, what support you have, and do no harm if you cannot do any good for the patient. All these literature reviews, unfortunately, even today, the newer studies tend to be more diverse in conclusion. And the older studies favor early fixation. So it is confused. Even today, it is confusing. I have a large review of literature here, which I won't go on with, but it is like an elephant being seen by a blind man. We are still not sure whether it is a snake or a rope or a sphere or a fan, but we are sure what to do and what not to do. So all these publications, right from 1990 to almost 2013, emphasized surgical strategies in polytraumatized patients with femoral shaft fractures. Comparing a German and an Australian level one, they emphasize you fix the fracture shaft of femur. Where this paper says when should we operate on major fractures in patients with severe head injuries. All these envisage and give a different view depending on the patient, because we must understand each patient is different, surgical approaches are different, the institutions are. So what is best for the patient, you will have to undertake. And a risk-opted approach is beneficial in the management of bilateral fractures of the femur. Even so, with multiple femoral fracture trauma patients, analyzed based on the trauma registry of German Trauma Society, envisages that DCO is much better. Timing of definite treatment of fracture shaft femur in patients with multiple, a systematic review, randomized and non-randomized, said if there is a chest injury, you shall not operate on the fracture shaft femur on day one. And especially this lead paper tells evolving lung injury, you may not have a contusion at the time, you may not diagnose, but the patient may be having a contusion, so you'll have to be careful. So all this, even Pape's paper, pulmonary function can change within hours after injury. Hence, repeat blood gas analysis, APG, should be obtained. Hence, it is recommended that such cases be nailed in a delayed manner. Data supports that the presence of chest injury is a more important factor in development of ARDS than the type and timing of fracture surgery. I will just show you what type of, unfortunately, I can't ask question face to face, but you think of what is to be done. Unfortunately, they already put it there. So here is a 42-year-old male. He came to us within 3 hours after injury, and he was brought to the care and with this particular, he had a distal femoral fracture, he had a proximal tibia fracture, he had a fracture on the right side, the shaft of the femur, and the intertrochanteric fracture as well. And he had also the fracture of the both bones of the forearm. He had a fracture of the shaft of the humerus. He had an intercondylar fracture of the elbow, as you see. So what will he do? The patient was stable, conscious, no obvious injury with an ultrasound. Chest injury was ruled out. So we thought we'll do an ETC, early total care, immediate management. So intramedullary devices for the femur and the tibia was fixed, and the humerus and the forearm and all these fractures was fixed except the elbow injury because of the time lag, and that was taken up after. See, look at this. This was nearly 10-year-old, not the latest type of plate, but still it was fixed very well. The fracture of the distal femur, the proximal tibia, and the intertrochanteric fracture. And that is the picture which you see. And the fracture shaft of the humerus was fixed with the plate. The intercondylar fracture of the humerus was fixed after 5 days, as I told you. And both bones of the forearm and distal radius also was fixed with plates on day one. And the intercondylar fracture of the distal radius was fixed on day 5. This is an early total. This is 6 months later. And you see every fracture has united so well. And the patient has gone back to work in just about 3 months' time. That is early total care. If you really understand the patient well, the injuries well, whether you can go ahead with the early total care. Where here is a patient who is 22 years old. He had a cerebral contusion. GCS was 10 by 15, and he had an anterior column with an ipsilateral sacral fracture of the pelvis, and he had a B2 shaft fracture femur, C3 distal humerus. He was hemodynamically stable. There was no acidosis. So first, second, and third, fourth rib fractures with mild pneumothorax, and he was not more thermal. What will you do? Is the question. Will you go for DCO, ETC, or early appropriate care? Because he was almost normothermic, and he had a hemodynamically stable. We thought we'll fix his fracture shaft of the femur as an early appropriate care. And this fracture shaft of the femur was fixed on day 1. And day 5, where the window of opportunity was there, his anterior column fracture was fixed. And all the other fractures which he had, the patella, all were fixed. And including the distal humerus fracture was fixed on day 7. So that is a classical early appropriate care patient. Whereas look into this patient with a 66-year-old lady who sustained injury following RTA. Patient presented 3 hours after injury with a bilateral thumb swing. Pulse was feeble and semi-conscious, and she was a hypertensive and also a diabetic. She had this fracture of the distal femur open, distal tibia open type 1, and the other side, a fracture of the tibia and a distal femur on the other side. They had a shattered fracture supracondylar on either side and fracture of both bones of the leg on either side. And look at this picture. And she had an injury to the foot, and she had a fracture of the humerus, and this was an ideal case for a DCO. She was 66-year-old. She was semi-conscious. BP was low, and she had multiple injuries. So all that was done was the DCO, where external fixator was put to both the limbs, and early debridement of the other wounds were undertaken. And this was the picture of an external fixator in situ. And on the 6th day, both the fractures of the supracondylar fractures were fixed. Not only fixed, but with bone grafting because so much of shattering of the bone had happened. And the nailing of the tibia was done on the right side, and the same side fibula was used as a fibula graft for the shaft of the femur. And the nailing was done those days. We were fond of nailing nearly about 8 years ago. Even today, we do a lot of nailing for the fracture shaft of the humerus, but it's a multi-lock nail. These were the conventional old AO nails, which you see here. And this was, you see the fibular stud graft and the long plate being put. And this was the final picture, finally, after 6 months. And that was a 2-year follow-up. All the fractures have been inverted with a proper DCO, damage control orthopedics, has saved this, not only saved this patient, but has mobilized the patient and back to her life. And that was the picture. So, gentlemen, damage control orthopedics is not doing nothing. Many people think damage control orthopedics is just you will sleep over and no. It is an excuse, nor it is an excuse to stay in bed in the night, late in the night, nor is it a convenience for the surgeon. It's a regression to the old techniques. First a fall, do no harm, and then repair. So the take-home message in this polytrauma patient is very clear. Polytrauma patients are vulnerable to second hit. That's why the ETC had a vaccine. Risk stratification of polytrauma patient as PAPE, which I mentioned, has to be undertaken. Aggressive initial resuscitation is the key for ETC, early total care. And this is best done at tertiary care centers where every facility is there with dedicated, efficient polytrauma teams. And DCO is safer alternative for borderline or worse patients in smaller centers. And early appropriate care perhaps is the balance between the two. Thank you. If there are any questions, I'll be too happy to answer them.
Thank you very much, sir. That is a very excellent talk. I am sure our postgraduates have understood the concept of early total care, early appropriate care, and damage control orthopedics. It will help them also in theory as well as when they work in the trauma center. Thank you very much, sir. That is a very simple and very appropriate talk. I'm sure our students have understood. If they have any questions, they can send, or we will share in the group, sir, so that everybody will know about the doubts and replies.
Yeah.
So, sir, thank you very much for your time, sir.
Thank you. Nice to be with you. Thank you.
Thank you, sir. Thank you so much, sir.
Wonderful job.
Thank you, sir. We'll end the meeting, sir.
Thank you. Wonderful.
Thank you.
Thank you. So thank you, Edward. If there is anything, they can telephone to me and ask questions also. It's fine.
Okay, sir.
Also,
Okay, sir.
send a letter. I will be too happy.
Okay, sir. Thank you very much, sir.
Thank you. God bless you.
Thank you. Thank you, sir.
Nazrat sir. Nazrat sir.
Yeah, tell me. Yes.
We'll end the meeting, sir.
Yeah, thank you very much. Thank you. We'll end the meeting.
Thank you, sir. Thank you.
Thank you.